The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'll introduce our speaker. Dr. Emily Casanova's research background is in embryology, genetics, neuropathology, and bioinformatics, with particular focus on neurodevelopmental conditions and a strong emphasis on autism. She is a research assistant professor at the University of South Carolina School of Medicine in Greenville. These webinars are made possible through generous donor support, including a grant from Local 25 Boston Teamsters. If you'd like to contribute, please visit our website at autism.org. And now I'll turn it over to Dr. Casanova.
All righty. Okay, thanks very much, Denise. I know the advertised title for this lecture was going to be updates on Ehlers-Danlos syndrome and autism, and so we're still going to be talking about those two topics, but going in a little bit more specifically. I want to take autism as and use it as a lesson for Ehlers-Danlos, because there's been a lot more research on autism compared to EDS. So I'd like to take some lessons from autism. So let's start thinking about Ehlers-Danlos syndrome and the related hypermobility spectrum disorders as a complex condition. And we'll talk a little bit more about what that means. Hold on a second. Here we go. Okay. All right, so a few weeks ago, I attended the meeting for the International Society of Autism Research, which is the big yearly meeting for autism research. And I had the pleasure of taking part in a lunch meeting with a number of autistic people and talking specifically about what issues were most important in terms of research to this community. And I was very pleasurably surprised to hear that hypermobility related conditions are a big topic amongst the adult autistic population. Why is that? Well, I can tell you, as somebody who herself experiences a hypermobile spectrum disorder, these conditions are chronic and they can be painful. So you can imagine why, if they're occurring more frequently in the autistic population, why they're a big popular topic with this population, and we really need a lot more research into this area. So I'm hoping that I'm the first of many soon to come. I think this area of interest is going to grow. So I did a webinar a number of months back with ARI, and we talked about the overlap between autism and EDS, and I'm just going to review a little bit of that again for any of you who aren't familiar. So there have been a number of studies that have looked at things like joint hypermobility, which is a major feature of Ehlers-Danlos syndrome and the hypermobile spectrum disorders, and looked at joint hypermobility in autism. And so there's been some significant correlations between that feature and occurring within the autism spectrum. We ourselves also did a small study looking at adult autistic women and comparing autistic women with generalized joint hypermobility versus those without. And some of the things we found was that women with generalized joint hypermobility were reporting more symptoms, more immune symptoms, and more hormonal symptoms. We've continued to do work on that and have done an additional study and hope to continue doing some clinical studies expanding on that. But I will go into a little bit later some of the things that we found in terms of detail. Unfortunately, I really know of only one prevalence study that's been done that has looked at the comorbidity between Ehlers-Danlos and autism. And this was an article that was published back in 2016 by a Swedish group. And they basically did a registry study. And they found that about 3% of individuals diagnosed with Ehlers-Danlos syndrome also had an autism diagnosis. Now, I have to say that is probably an underestimate, given that EDS tends to occur almost always in women, especially when referring to the most common form of EDS, which is hypermobile EDS. And so we're also, many of you may also be familiar with the idea that there are some concerns about the diagnosis of female autistics, in that they're often misdiagnosed, or the diagnosis is missed entirely. So that probably is an underestimate, and then the numbers of autism diagnoses in the Swedish registry should probably be a little bit higher, given the gender disparity that we see with Ehlers-Danlos. From my own personal professional experience, as well as my experience as a patient, there seems to be a lot of broader autism phenotype in Ehlers-Danlos and the hypermobile spectrum disorders. We don't quite know how much. That's another study we're planning on, so we hope to do that in the next year or two. Also, currently, we're working to finish off our latest publication, polishing that up at the moment, in which we report that EDS mothers are reporting a very high number of having autistic kids. And we found that 20% of EDS moms were reporting this, and which is actually as high as the rates of autism in kids from moms who have autism themselves. So again, these are preliminary. This was done from a survey study, and so we're really hoping to follow this up in the clinic and see if those numbers are at all comparable. So many of you watching this, you may already know what EDS is and the hypermobile spectrum disorders, but for the sake of those of you who don't, these are connective tissue disorders, all right? They generally involve generalized joint hypermobility, which means that the joints are hypermobile or double jointed across multiple joints of the body. Usually there's a certain element of skin elasticity. You can see the gentleman in the picture over at the left is an extreme version of this. But usually the most common form of hypermobile EDS does not tend to be quite that extreme. And then also there's tissue fragility to varying degrees. So there can be issues with scarring and bruising and things like that. It may affect the internal organs. Many times there may be hernias that occur. And most individuals will also experience chronic musculoskeletal pain and instability. And in fact, for some of these conditions, especially the hypermobile EDS, that's a primary criteria. There are also many secondary issues, and I hate using the word secondary as though they're unimportant, but I use secondary in the way that, unfortunately, the current criteria do not include these secondary symptoms, even though they're extremely prominent in this population. And that includes immune issues such as mast cell activation syndrome, various dysautonomias like postural orthostatic tachycardia and orthostatic hypotension. And then we've also noticed that there's some usually reproductive hormonal issues that may be in the form of endometriosis or polycystic ovary syndrome, etc. So there are currently 13 recognized types of EDS, and many of them are associated with collagen mutations or mutations in collagen-related pathway genes. Most of them tend to be very rare. The major exception is hypermobile EDS, which composes the majority of the EDS population, 80% plus. Unfortunately, it's also the only form of EDS that doesn't have any recognized rare mutations associated with it. We'll discuss more later on the likely reason for that. Classic EDS, at least from our studies, seems to make up about 20% of that population, and then the rest of the forms of EDS are very rare, and they make up only minimal percentage points. Prevalence overall, there are big debates about this. There have not been any recent good prevalence studies that I'm aware of, especially with changes in the diagnostic criteria back in 2017. And the official prevalence rate for EDS is 1 in 5,000. Most clinicians and researchers would firmly disagree with that, although they can't say what the prevalence actually is, but most believe that it's far more common than that. Some have proposed it may even be 1% of the population, though that may be pushing it a bit. The hypermobile spectrum disorders, those are a related group of connective tissue disorders. They don't quite make cutoff for hypermobile EDS or any of the other forms, but they still confer significant impairment, usually musculoskeletal impairment. Just to give you a little bit of background, this is very little, in terms of collagen. So we're talking EDS, usually we think of collagen disorders. So there's 28 types of collagen in humans, and 7 of those are considered fibrillar, which means that they make up collagen fibers. They're part of the structural components of the extracellular matrix, of the connective tissue of the body. So, and these are the different fibrillar collagens. Here I'm giving some examples of cross sections of skin. So these were taken from very small samples of skin from patients as well as an uninfected person for control. And this was done under an electron microscope, and this is just kind of cut right across the top of the collagen fibers so that you see the circular pattern. And you can see over here in the upper left with the unaffected person, there's a little bit of disorganization, but for the most part the collagen fibers are all fairly round and a little bit homogeneous in size, and that's mostly what you'd expect to see. And then when we start looking at these different forms of EDS, under the microscope, such as arthrochalasia, up in these upper 2 cases here, you can see in AEDS, you know, obviously there's considerable differences between just these 2 patients themselves, but you can see there's malformation of the shape of the collagen. They're small, they're tiny, they're angular. Down here in the lower left is an example from someone with classic EDS, and those are a little bit more homogeneous, but you can see that there's changes to size. You've got some of these large rosette patterns. And finally, over here on the far right, you've got a case of classic-like EDS. And you can see that the collagen fibers themselves look fairly homogeneous, but then there's a lot of space in between them. So there's different things that are occurring in each of these cases to the skin, but they all ultimately lead to changes in skin elasticity and joint mobility. You can also see something similar in cases of hypermobile EDS. As well as in their unaffected family members. So that's a big curiosity. Here you can see some of the rosette patterns that we saw a little bit in classic EDS. There's also some microcysts, some calcified microcysts in the skin, as well as some of these probably hyaluronic acid-filled globules here. And so these are seen in both individuals with hypermobile EDS as well as some of their non-hypermobile family members, individuals who would not reach criteria for hypermobile EDS, suggesting that there may be something more that's occurring in hypermobile EDS to cause the significant impairment, and it's not just a deficiency in collagen formation. So to kind of go back to our latest study, the one that I'm working currently on polishing up and getting out, we're really interested in some of these, quote, secondary symptoms in EDS. In particular, we're very interested in the immune system and the autonomic nervous system, and as well as the reproductive system, but especially the immune system and the autonomic system, as conditions associated with this kind of dysregulation, such as mast cell activation syndrome and POTS, can often be more impairing for an individual with EDS-HSD than sometimes the musculoskeletal pain and instability itself. And you can see here in terms of the immune system and autonomic and endocrine dysregulation, the EDS group in yellow is reporting the greatest number of symptoms. Now, interestingly, also, those with autism but without any hypermobility, these are all women, I should say, this is all females, as well as the controls. The autism group is kind of in the middle. So it's showing some trends similar to EDS-HSD, but just not quite as severe as that subgroup. So that's very interesting. That's something that we want to continue to study. So we're very interested, especially in the immune system in EDS-HSD, as well as in autism. And but why is the immune system affected in these connective tissue disorders? Well, one, I'll tell you, we don't know. However, one of the hypotheses, and if we take a lesson from a related connective tissue disorder known as Marfan syndrome, which many of you are probably familiar with, there are many Marfanoid features that we often see in Ehlers-Danlos syndrome, and I don't think that's coincidence. But if you take Marfan syndrome as an example, so these people often have mutations in the fibrillin-1 gene, and fibrillin is part of the extracellular matrix. It's one of the important proteins in connective tissue along with collagen. And you can see here that fibrillin is actually helping to bind something called TGF-beta. And TGF-beta is a really, really important immune-related molecule, helps to regulate activity of the immune system. And what fibrillin is doing is it's actually acting as a storage compartment for TGF-beta. So your body can make up a whole bunch of this in advance, store it on the connective tissue, and then when it's needed, very rapidly it can be released. You can imagine that's really important. So for instance, if you have a major cut or injury, you don't want to have to wait for your body to go to that gene, transcribe that TGF-beta gene into RNA, and then finally translate it into protein so it can be used. That can take up to a half hour or more. You could bleed out and die by that point. So you can imagine that having a lot of immune-related molecules, a lot of immune modulators, waiting and at the ready is really important to the preservation of life and health in general. And so one idea is that, similar to fibrillin, collagen may be doing some similar things. Either it's directly binding some of these proteins, or it may be binding to the fibrillin and also affecting that relationship. Right now we don't know, but that is definitely something that we are planning on studying in future to get a better idea of why immune disorders are occurring so regularly in these various related connective tissue disorders. And that includes Ehlers-Danlos and the Hypermobility Spectrum Disorders. It includes Marfan's, and it also includes a condition known as Loeys-Dietz syndrome. So that's something we're hoping to study in future. Now, for those of you who have EDS or HSD and also have immune problems and autonomic nervous system problems, which is probably the majority of you, you may be interested in why these different systems seem to all go wrong together. And so here we're going to look just very briefly at the relationship between the immune system and the autonomic nervous system. All right, so by autonomic nervous system, this is the part of the peripheral nervous system that's out in your body. It's not the central nervous system. It's not the brain and the spinal cord. These are all of the neurons and nerve fibers that that extend out into your peripheral body, innervating organs and skin and all sorts of tissues. All right. And when we're talking autonomic, that's almost like automatic. That's the stuff that your nervous system does for you that you don't have to think about. So it's related to cardiac function and digestion and things like that. So when we're talking about how the immune and the autonomic nervous systems may be affecting one another. So for example, here in this upper left-hand corner, we have an image, this diagram of some pain-related fibers, and we have in purple these mast cells, all right? Mast cells, for those of you who aren't familiar, this is a very important player in the immune system. It's part of the innate immune system, which is your first rung of defense, as opposed to the adaptive immune system, which has to do with T cells and B cells and immune learning. It's basically you get an infection, you develop antibodies, and your body learns in future how to fight that infection off much more easily. But this is the innate immune system. This is the most ancient immune system. And you have mast cells in your skin, in your digestive tract, in your respiratory tract, all over. All right, and they're your first rung of immunological defense. And so these guys, they get exposed to a lot of stuff. And so you can see here that these mast cells in purple, not only you've got one mast cell here in example A, where it's actually binding to the synaptic receptor here on this pain fiber. You also have mast cells that are releasing molecules into the synaptic cleft and communicating that way. So there's a number of ways in which these mast cells are actually affecting the behavior of nerve fibers. All right. Now, we also have another way how the immune system can communicate with the central nervous system. And so here on the left, we have an example of diffusion, and that's carried out in areas known as the circumventricular organs. I won't ask you to remember that, but just remember that there are certain areas in the kind of the barrier between the brain and the cardiovascular system that is in the brain, where there is no blood-brain barrier. There's no significant barrier that keeps those molecules from diffusing across into the nervous tissue. So there's kind of a free flow, and that allows for very rapid response from the central nervous system when the immune system is activated. Now, on the right, you also have transport, all right? So this is at the more traditional blood-brain barrier. Not a whole lot gets through there without permission, and so you can have various interleukins and other cytokines and chemokines that can be transported across the blood-brain barrier by channels. They can be physically transported. So those are another two options, the ways in which the immune system from the periphery and basically molecules released into the cardiovascular system can then communicate with the brain itself. Then the brain then can also have a top-down effect and end up helping to regulate activity of the immune system in turn. Examples that include, for instance, mast cells have things like serotonin receptors and other types of neurotransmitter receptors. So they are responsive to things that are released in the bloodstream and into local areas that are traditionally considered nervous system related molecules. All right, so now I'm going to go into a little bit of genetics, so please stay with me. Hopefully the concepts won't be too difficult. I'll try to explain them as best I can. So in genetics, we tend to think of conditions in a kind of a black and white fashion. And we think of them either as rare conditions or as complex conditions. Now, there's definitely a spectrum that occurs between these two extremes, but these are kind of generalizable concepts that we use. So typically, when you have a rare condition, oftentimes the genetic variant that's associated with that condition tends to be more harmful. All right, you can imagine the more harmful a mutation, the less likely it's actually going to get passed down to the next generation. So they tend to get weeded out just naturally. All right, and so those conditions that are rare, that tends to be the genetic stereotype, shall we say. But we also know that 1 in 10 people in the United States at least has a rare condition, meaning that even though they all usually have different rare conditions as a whole are actually rather common. Rare, of course, here we're using the definition as approximately 1 in 2,000 to 3,000 people. Many times these rare conditions may be associated with one or a handful of rare genetic mutations. Now, when we're talking about a complex condition is usually defined as a clinical syndrome, and it's defined symptomologically. And typically it has, as the name implies, it has a more complex genetic and environmental background or etiology, and it usually occurs in greater than 1 in 2,000 people. So just to kind of give you a little bit of a diagrammatic illustration here, we've got rare on the left-hand side and complex on the right. Rare, of course, they're more rare, as given by the name. They're usually more severe in terms of phenotype, in terms of symptoms. Sometimes they can actually be extremely deadly. That also includes conditions in which, for instance, an infant may not live very long after birth. They may be totally dependent on the mother in terms of nutrition and survival. many times they are associated with rare mutations. By rare, we mean that a mutation or a genetic variation occurs in less than 1% of the population. Anything below 1% is considered rare. Anything above that is considered common. So complex conditions on the right-hand side, obviously, as I've said, they're more common. They tend to be less severe, although that's not to undermine the impairment that may occur in some of these conditions, which still can be severe to an individual. But if you're comparing them to rare conditions, they tend to be less deadly, for instance. They may occasionally be associated with rare mutations, but that tends to be limited to a minority within that population. And really, when we're talking about genetics, with this group of conditions, we're interested more in polygenic risk. And I'll go more into what that means in future slides. But as you can see here in this slide, complex, we associate that with far more people here down at the bottom, and then rare, far fewer individuals. Now, if we're talking about Ehlers-Danlos, typically when we think rare, we're probably talking about classic EDS, things like vascular EDS and kyphoscoliotic. But on the other hand, complex, that probably applies to a large portion of the hypermobile EDS population, given how common they are compared to the rarer forms of EDS. That also most likely applies to the other hypermobility spectrum disorders, and also possibly to asymptomatic generalized joint hypermobility, which can occur in up to a quarter of the population. So when we're talking hypermobile EDS, so there probably are a small number of cases that come up with rare mutations, and they may have a little bit more in common with the rare side of this spectrum. But my guess is dealing with some other complex conditions, we'll probably find that the bulk of hypermobile EDS does not have an obvious genetic underpinning. That doesn't mean it doesn't have a genetic underpinning, but it may be much more complex in order to identify. So here are some other examples. And obviously, we're talking about autism here in large part, autism and overlap with EDS. And we're using autism kind of as our example because we've done so much more work in autism than we have in Ehlers-Danlos. So in terms of complex conditions, autism, things like asthma, diabetes, rheumatoid arthritis, multiple sclerosis, et cetera. All of these conditions are considered complex. A small minority of individuals seem to come up with rare mutations. The rest of them, we don't quite know. And may also have some environmental influences on whether a condition develops or not. So again, taking autism as an example, because so many people think of autism, but they don't think of some of these rare forms of autism. Or if they do, oftentimes they just kind of put it over to the side and they say, oh, well, that's not quite autism. That's not real autism. Unfortunately, we can't quite make that argument because autism is a clinical syndrome made up of behaviors. There's no way that you can say that this thing is autism and this thing isn't autism, even though this other thing also meets criteria for autism. It's all autism, just like all forms of Ehlers-Danlos are Ehlers-Danlos. That doesn't mean that they're all the same condition. Like you can see here with examples from autism, you have Charge syndrome and Fragile X and Phelan-McDermott and Smith-Magenis syndrome. They're all different conditions. They have different genetic underpinnings, but they all conform to the clinical syndrome of autism. So if we start thinking of Ehlers-Danlos in that way, I think that would be very helpful, both for scientists and for patients alike. And you can see here, I'm just illustrating all these different forms of autism. They all funnel in, these different conditions, they funnel into the broader category of autism. And the same thing with Ehlers-Danlos. We've got all these different types and these hypermobile spectrum disorders and classic and vascular, and they all are somewhat unique as conditions, but they all have this common syndrome. So I'm going to go through a couple of case reports, a couple of examples, just to continue to hopefully help you expand your thinking on this topic. And so here, we're going to talk about a case report of a family with Van Maldergem syndrome. This is a very rare condition, in this instance, this is related to mutations in the GCHS1 gene, which is it produces a protein that's very important for fibroblasts, which are the cells that produce connective tissue. So in this family, they have 3 kids. Both parents have a heterozygous mutation in this GCHS1 gene. By heterozygous, I mean that they have 1 bad copy and 1 good copy, each of them. And so they're considered carriers or heterozygous, although they do have some medical issues as well. And 2 out of 3 of the children inherited both copies, both mutated copies. And so 2 of them have the VMS. They have VMS, Van Maldergem syndrome. And this is recessive. This is a recessive condition. In order to develop the full VMS, you have to have inherit 2 bad copies. There's another sibling in this family who's a carrier, who has 1 bad copy of the gene and 1 working copy. And she has an EDS or HSD-like phenotype. So here we're using this as an example. Even though this is a mutation in a cell adhesion molecule gene, it's really important in fibroblasts that end up producing connective tissue. This isn't a collagen-related gene. So we're actually, this gene mutation is actually having an effect at the cell level, not at the collagen level, but it ends up affecting the development of collagen. And so you can see how through this, looking at this pathway at different levels of the hierarchy, you can start to see how these different syndromes start to overlap, and they all can have features of hypermobility and skin fragility and things like that. Now, there's another case in the literature of Noonan syndrome. And there's a woman, this woman had all the features of generalized hypermobile spectrum disorder that you'd expect to see. She had generalized hypermobility. She had musculoskeletal pain and instability and impairment. She had extensible skin and easy bruising, had the high arched palate and scoliosis and chest deformity and arterial issues that you often expect to see with a marfanoid habitus, which is part of the criteria for EDS. But when geneticists did a workup on her, they found that she had a mutation in the SOS1 gene. And that's associated with a type of Noonan syndrome. And she actually had a few of the other features that would be associated with this type of Noonan syndrome, which also includes some facial malformations as well as some curly hair. So you kind of have this strange combination. This woman has Noonan syndrome. That's what this would be called. But she also has an Ehlers-Danlos-like syndrome on top of it because of this. And so this gene, I should mention, is involved in MAPK signaling. I won't go into detail as to what that is. Just know that it's a growth-related pathway. And you can imagine if this SOS1 gene is involved, for instance, again, in fibroblasts, you may affect how collagen is produced. Finally, just our last example here that I'm going to give. I'm currently working on a case studies report with some folks over at the Mind Institute in California, specifically with Rondi Hagerman, who's a major guru in the study of Fragile X. And we got to talking one day. We were at a conference together, and she was talking about her Fragile X patients, and I started talking about EDS, and she said to me, you know, it's strange, but we've had more and more cases cropping up of moms of kids who have Fragile X, and the mom turns out to have Fragile X premutation, and they have a diagnosis of hypermobile EDS. So I thought, my gosh, that's fascinating. Let's do a case report. The interesting thing about Fragile X premutation is, yes, Fragile X syndrome is rare. All right, but Fragile X premutation occurs in about 1 in 200 women, not rare at all. So it's quite possible, especially given the relationship between Fragile X autism and the clinical syndrome of hypermobile EDS, that there could be a minority of the hypermobile EDS population that may well be on this Fragile X spectrum. So we are, in this paper, we're going to be highly recommending to clinical geneticists, if they do a workup on someone who looks like they have a clinical syndrome with hypermobile EDS, to also throw in Fragile X premutation testing. The nice thing is that most genetics clinics tend to do this on a regular basis. So it's not something that they haven't done before and they're not used to doing. So I would also highly recommend to anyone who is going in for genetics testing, you know, just ask your geneticist if they'd be willing to throw in a test for Fragile X premutation. Specifically, I recommend the premutation and not just the full Fragile X mutation event. So we're hoping that that paper will be out in maybe the next 6 months or something. So we're currently working on that. All right, so here's the hard part. We're getting into some of the nitty-gritty of genetics, and none of this has been published. You're welcome to use this as you will. This is something I've just done for the sake of this lecture, but I want to get to the concept of many genes funneling into a common biological process in these connective tissue disorders. And I think we already started getting at that. You could see that you could either disrupt collagen formation, and that can lead to the Ehlers-Danlos syndrome, or you can also disrupt how the fibroblasts are actually producing collagen. So, and I'm sure there's probably other rungs on that hierarchical ladder. You could probably even go further up and see ultimately how it all funnels back down into collagen production and formation. So what I've done is I've gone on to the online Mendelian Inheritance of Man database. You don't need to know what that is, just know it's a whole big collection of a lot of rare syndromes. Many of them have genes that are known to be associated with them. Some of them they don't know yet. And what I did was I keyworded for symptoms of hypermobility or joint hyperextensibility. And I got this list of 50, 60 something genes. All right, here on the left-hand side, all of these little boxes, each of these are genes. And all the red ones, those are the original genes associated with all of these different conditions, these rare syndromes that have hypermobility, all right, joint hypermobility. I then took that list of genes, then fed them into something called Gene Mania. Again, you don't need to know what that is, but what that does is it feeds back to me what other genes do those genes then interact with. All right, so I've got this network here in red and blue. The red ones, as I said, those are the original seed genes. The ones in blue, those are the next layer of interaction genes. And these are all of these protein-protein interactions, all right? Anything that's in these networks, if they have connections between them, these are proteins that are known to directly and physically interact with each other, potentially affecting the behavior of each other, all right? And so this whole gene list, and you can also see, obviously there's a lot of genes here down at the bottom in these lines that do not seem to have direct physical interactions. Those probably a little bit more complicated, but we do have some significant networks forming. And these significant networks, they seem to be overall involved in organization of the extracellular matrix and in organization of collagen, etc. All right. Now, when we look at these networks and we break them down, we have two major bundles of interactions, and they're connected by something that we would call hubs, all right? These are proteins that are connecting both of these networks together, so they potentially can funnel into one another. And so up here in the red circle, we have the extracellular matrix-related network, all right? This is mostly what these genes are involved in, okay? And so, and most of these, as you might imagine, a lot of these genes are the Ehlers-Danlos related genes. There's some other ones in there as well, but it's mostly EDS genes. Now, down here on the bottom, when we're looking at this blue circle, a lot of these genes are involved in gene expression regulation, and specifically in helping to regulate the timing of development of cells. So again, you can imagine if these pathways are involved in helping to regulate the development of fibroblasts, for instance, and that is affected, you may ultimately end up affecting collagen development too. All right, so you can start to see how these two major networks here of hypermobility related genes, how they potentially interact with each other, but can also be somewhat unique. They're forming unique networks that are interlocking with each other and can potentially affect the behavior of either one. Now, if you take a look at, I just took a list of 50 randomized genes. I just took 50 genes, random genes from the genome, and plotted those into the same exact thing. And you can see that none of them are interacting with each other. There's no protein-protein interactions here at all. So this really suggests to us that these networks are real, that you have some significant hypermobility related networks here that we're starting to see. And we're hoping in future we can maybe build some more on that and figure out what's going on. Now, we did this earlier, and this is from a published study that we did published last year in Frontiers, doing something similar with autism, specifically autism with intellectual disability, because most of the genes that are associated with autism are associated with autism that also has intellectual disability. Again, this is the element of rarity. These are rare conditions, and so they tend to be more severe. And so that usually involves an element of cognitive impairment as well as the autism. But you can see, so in this large network here, these are all autism-related genes. They have a very strong relationship with autism. And these are divided by color. And what the colors mean, they're associated with different symptoms that are also associated with these conditions. So some of them, for instance, some of these networks are associated with facial malformations. Others have features that are sort of neurodegenerative-like. So these networks, these colors were formed based on those combination of features in addition to the autism that's already present. And so we can see that based on the autism and these phenotypes, these symptoms, they're forming individual, very unique clusters, but they're also overlapping. Here you can see this big MECP2. That's a major hub for at least 3 of these big networks, which suggests again that at least for these conditions, the autism may be somewhat similar in terms of pathways, in terms of cell biology and function. So not dissimilar to what we're seeing back here with these hypermobility related genes. We've got some hubs here and they're funneling in, and they may ultimately lead to a similar phenotype, a similar clinical syndrome. All right, so still got a little bit of the hard part left. We're going to go into a little bit about polygenic risk in autism. All right, so stay with me. All right, so when we talk about polygenic, right, we're talking about many genes. All right. And usually when we talk about polygenic, we're referring to common genetic variations. That means that a given genetic variation occurs in more than 1% of the population. If it's less than 1%, it's not common. It's considered rare. And usually we refer to that as a mutation. All right. So whenever we're talking about common genetic variations, most of the time we tend to be referring to single nucleotide polymorphisms, or SNPs. All right, and these are the genetic variations that you're looking at if you get something like 23andMe done, or Ancestry, or any of that. Those are common variations in the genome. That's something any of these are occurring in more than 1% of the population. All right, now we already know from past data that autistic populations tend to have a more similar SNP profile than you would expect at random, and that includes, adapting that, accounting for race. Okay, because obviously, if you're from the same race, you have a much similar genetic background. All right, so people with autism tend to have more similar common polymorphisms. All right, on average, but there's some research that suggests that this kind of polygenic background can also have an additive effect when you put a small effect mutation on top of it. All right, so to kind of explain this concept, all right, this is let me call this the addition of genetics. All right, this is how we add these together. All right, So polygenic risk in autism. Up here, this dotted red line, we have, let's just call this the syndrome threshold, all right? Anything above that line and you develop the autism phenotype. Anything below and you don't. I know that's a simplified concept, but we're just using this as an illustration. So over here on the far left, you've got this string of letters. These are all, we're going to pretend these are nucleotides. This is a string of DNA. And over here, you don't have any of the polymorphisms that are associated with the risk of developing autism. All right, so there's no, this person does not develop autism. They don't have this clinical syndrome. Now, the next over, this individual has 3 different polymorphisms that are associated with increased risk for developing autism. And so they end up making genetic cutoff for developing the condition. All right. Then the next one over, you have one SNP here, you have one common variation, but then this person also has in the X, they have a minor rare mutation. It has a small effect, but when you add it together with that other common risk factor, they end up making cutoff for autism. And then finally, at the very end, you don't have any of this common risk background, but you have a major mutation event. Here you've got the big red X, and this pushes this person over. So regardless of background, this person was going to develop autism with this particular mutation. All right, so these are just some examples of how we tend to think of genetic variation, whether it's rare or whether it's common, and how it can either have a protective effect or risk effect for any given phenotype, any given trait. In this instance, we're talking about autism. Okay, so in some instances, it may mostly be a polygenic effect with common variations. And that takes a lot more skill for geneticists and for a bioinformatician to be able to identify those, because you imagine this is kind of a complicated genetic thumbprint. It's why we know much more about rare mutations than we do about common variations that end up affecting risk. All right, but you can also have rare mutations that end up only having a small additive effect, or you may have large mutations that have, and I don't mean large necessarily in size, although that can also be the case. Sometimes entire genes can be taken out, but really major effect mutations. And they're usually tend to be very detrimental to the function of a gene. They may knock out its function entirely. And that ends up being potentially a big risk factor for something like autism. So is something similar happening in Ehlers-Danlos syndrome and the hypermobile spectrum disorders? You know, we don't know. My bet is probably yes, which is why the HEDGE study, which is currently the new genetic study doing full genome sequencing on individuals with hypermobile EDS, why I think that will only be the first step. You know, it's going to take more time. They'll initially be able to identify individuals who have rare mutations, but as I suspect, it'll probably only be a minority of cases. The rest of individuals with hypermobile EDS and with hypermobile spectrum disorders probably are going to have a more complicated genetic background. And at that point, we're going to need to basically take to computers and analyzing complex data and patterns. We can do that. It's just a slow process, and we're still perfecting methods at this time. I should say that if you are interested in partaking in this study, do please copy this link down at the bottom. The more, the merrier. I know not everybody is super fond of the EDS Society, to each their own, but this is a really important large study, and hypermobile EDS desperately needs this. This is the first step in genetics research. Now, I also am going to question too, not only whether genetics is going to be the full story, all right? And so I wonder myself also, how much does environment potentially play a role? So for instance, there's a lot of individuals, there's almost kind of a subtype of individuals with hypermobile EDS who, yes, they've had generalized joint hypermobility their entire lives, but they did not develop the significant impairment until adulthood, maybe well into their 20s or 30s or even 40s. And then it was triggered off by something. Many times that may be a surgery or an acute infection like Lyme disease, or even something like pregnancy. So there's definitely a subtype in hypermobile EDS that seems to conform to this pattern. So it may not all be in the collagen related genes in these individuals. And so this is also a reason why we're very interested in the immune system, as well as in the immune system for autism, because we are finding some indication of a relationship between the severity of a mother's immune disorder and whether or not she has children with autism. It's still early days and we're following this up clinically, but so far there's some indication that the immune system could also be a major factor in whether a person ends up fulfilling full criteria for hypermobile EDS or the hypermobile spectrum disorders. So, all right, well, that's my talk. I hope everybody's eyes aren't crossed with all the genetics. I apologize if they are, but I thought it was an important topic and something that we're needing to learn and study much more. So thanks very much, and I'll take any questions as they come.
Okay, great, Emily. Thanks for that talk. We do have some questions, and I have some questions that were sent in ahead of time. So I'll read these out to you now, and we can answer as many as we can in our last 7 minutes. One question we actually got, a person typed in, they were asking about the relationship between Marfan syndrome and autism, and I think relating to your talk about EDS. You touched on that a little bit. Do you want to expand on that more?
Sadly, I am not aware of any studies so far, but I am wanting to take part in those studies. I have been talking with some clinicians who have been dealing primarily with autism clinically, and they have noticed that they have a number of patients with Marfan's. So I know there have been studies finding an increase in neurodevelopmental conditions like autism and ADHD, definitely in a related condition known as Loeys-Dietz syndrome. So the fact that we're seeing it in Ehlers-Danlos and in Loeys-Dietz, I would be absolutely shocked if we don't also see it in Marfan's. I just think it hasn't been studied yet, unfortunately. But I'm really hoping that can be done either with our group over time, or if I can just kind of spur on interest in others who are already studying Marfan's. So that's my hope.
Okay, the next question was about adulthood. You were talking about this, or just talking about the subgroup of people who appear to become triggered by a big autoimmune event or an immune event. So what types of symptoms would people be looking for if they suspected they might be experiencing it?
Oh gosh, I mean, it really varies on what the stimulus was. You know, it really, anything that's going to potentially tax your immune system, you know, it is a potential trigger. And that, you know, that unfortunately can also include vaccinations as well, which was not one that I mentioned. So really anything that triggers the immune system. At that rate, you may expect to have kind of an acute phase. Probably most people would experience some kind of acute phase where, you know, you could develop fever and chills and things like that. But, you know, honestly, it probably varies by person too, though. You could end up having anaphylaxis or, you know, multiple organ issues in terms of skin problems and respiratory all of a sudden, or major chronic fatigue. Chronic fatigue is a big one that's often reported, especially very early on. You know, and that the chronic fatigue is probably related to prostaglandin release, which is the lovely little protein that the immune system releases when you get sick, and that travels up into the brain and communicates with the brain, and is the one that makes you really tired. unfortunately. It's good when you have an acute illness, like if you have the flu or something, yes, you need to lie down and rest. But if you're having a lot of prostaglandin release on a continual basis, that is one thing that can potentially cause the chronic fatigue issue. So, and also is why that's one of the major molecules that they try to test for in urine when they're testing for something like mast cell activation syndrome. I'm not familiar with autoimmune conditions. I wouldn't be surprised if that's also similar in terms of testing. I mean, but you know, honestly, the anything immunological, any kind of immune symptoms that are kind of sudden onset, or an increase in severity to what you're used to, and then fatigue are probably some of the major ones you'd expect to have.
Okay,
it's not a guarantee though. Everybody's unique, right? So
right.
Yeah.
The next question's about a child then. So if this person's asking, she has a 2-year-old, she's wondering about symptoms and how it fits. So what are things parents are looking for as, you know, very specific signs that they might watch for?
In terms of the EDS stuff, so, you know, in a 2-year-old, truthfully, I've never tried to assess a 2-year-old. Kids tend to be more hypermobile, just period. All right, their joints are still developing. So the criteria for meeting hypermobile EDS in a child is it's a higher cutoff than it is for an adult. And actually over the lifespan, the number of joints required to be hypermobile in order to meet criteria actually decreases with age. So anyone who is a senior citizen, for instance, they don't need to have as many hypermobile joints as an adult in their 20s and 30s. The same can be said in relation to a child. As far as a toddler, the hypermobility, that's tough. They can look at things like joint laxity. Your pediatrician or your developmental pediatrician, if they're being followed at a clinic for the autism, you know, they can usually test as far as joint laxity and those sort of things. The other thing to look out for, I have heard of some individuals talking about, since the things like mast cell activation syndrome occur so frequently with conditions like Ehlers-Danlos, sometimes toddlers will turn up with those kinds of symptoms and will have asthma and skin problems and you know, maybe other types of respiratory problems, and of course GI problems. I mean, that's a big one in autism. And you can have GI problems either because of an immune issue or because of an autonomic disorder, or both, since they seem to interact. But I would say there's not a huge amount of information on really, really young cases of EDS, HSD. Maybe actually some of the parents who themselves have hypermobile EDS and have kids with it, they may be actually better able to respond to your kind of questions. So, you know, I would also very much recommend, you know, online patient groups of EDS. They are a phenomenal wealth of information. I have to say that's where I've learned most of my information from. They're way better than scientists and clinicians. Not to insult scientists and clinicians, but you know, these are the patients that live through it, and they have to learn as they go, and they teach each other, and there's a lot of patients out there. So they're a really great resource. I highly recommend it.